Welcome back to our ongoing series of lessons on how to develop an optimal therapy practice by promoting interdisciplinary care at the intersection of faith and neuroscience. We're going to talk today about the CPA Baseline Report, the second page that focuses on depression. The NIH Depression Scale results are presented here. This scale covers items 9 through 16 from the CPA Report first page, items that are all focused on depression. The raw score is presented here, along with a percentile ranking and the interpretation of the percent of people who report fewer or less severe or less frequent symptoms. This section starts with a definition of depression that's based on the DSM-5. It's important to recognize that depression is much more than just sadness. For that reason, I want you to pay close attention to this definition. Depression can combine negative feelings such as sadness or guilt or worthlessness to cause social isolation and loneliness. People who are depressed are less interested and engaged with life and have less meaning and purpose for their lives. Depression can also cause changes in appetite, nutrition, and sleep patterns. The report doesn't say it here, but obviously depression is the primary cause of suicide. I want you to use this paragraph to help your client begin to understand that depression is not just a synonym for sadness. Depression extends far beyond depressed mood. We need to get away from the idea that just improving the mood solves the problem. Obviously, it doesn't. Consistent behavioral change supported by counseling and coaching are absolutely necessary. The problem is that as depression persists, it harnesses neuroplasticity. Basically, depression hijacks the links between the hippocampus and the amygdala. Other brain centers are involved, but this is where depression has the most leverage because it colors all of our thinking. Major changes in brain linkages occur that cause changes in perception and behavior. Major changes also occur in brain chemical balances that cause changes in mood and sleep and emotional resilience and even intellectual capacity. And this is the major reason that the cure rate for depression is so poor. The sequenced treatment alternatives to relieve depression study from NIMH in 2004 drove this home. The long-term remission rate from depression given mental health services that spared no expense was only 50%. Rewiring neuroplastic change is a big job and requires persistence and diligence, which a good counselor can provide. Psychotherapy success is limited when people terminate counseling prematurely. Let me ask you a question. Which evidence-based practice, EBP, has the highest level of research-demonstrated efficacy? I've listed 12 here. Is it insight psychotherapy or a somatic therapy? Is it antidepressant medication? How about brain stimulation? Is it cognitive behavioral therapy? How about proper nutrition? How about having a healthy relationship with the therapist? Actually, peer-reviewed research shows that the order in which I've listed these is exactly backwards. Far and away and time and again, the healthy relationship with the therapist is most important. Research sponsored by the federal government's Substance Abuse and Mental Health Services Administration demonstrates that the therapy relationship is central to success. I want you to keep this in mind. We are beginning our relationship with a client who comes in with pain. Pain is providing the motivation to participate in counseling. As that pain begins to lift, the motivation to continue tends to lessen. This is especially true when people begin to have success with antidepressant medicines. Once the medicine starts to lift their mood, people stop counseling. Counseling and behavior change take effort and commitment and sacrifice. Antidepressant medicines are often necessary, but they need to fit within our interdisciplinary treatment plan. They can't be allowed to short-circuit the treatment plan. When that happens, many of the problems that cause the depression to surface are still there. So, what does this have to do with the CPA Clinical Interpretation Report? Well, I designed it to facilitate development of a healthy relationship between the therapist and the client. It can be an important therapy tool. It's important that the therapist and client plan to go beyond just elevating the client's mood. Carefully going through this section of the report is a good way to begin. When we get to the next page of the CPA report, to design the client-centered interdisciplinary treatment plan, this early orientation really helps develop the necessary commitment and buy-in from the client. And then we get to harness neuroplasticity for optimism and character development and joy. Alleviating the pain isn't enough. Our brains were designed for so much more. If you'd like to try it out for yourself, the CPA is available to counselors, psychologists, and social workers, and to interns and provisionally licensed professionals through their supervisor. We also support the free trial use of the CPA in clinical internship and residency programs. Contact us at faithfulbrain.com for further information. Thank you for your attention.